as principal investigator and co-investigator for numerous clinical trials regarding treatments for Parkinson's disease and other movement disorders. Dr. Evidente will now be joining Dr. Thakar and will respond to and discuss the questions that have been submitted for today's webinar. Dr. Evidente, please take it forward.
Okay, thank you. Okay, can you guys see my slides?
Yes.
Yes, we can.
Okay, very good. Okay, so the second part of the webinar is something new, and I think it's going to be fun. We actually did a little bit of it with Dr. Thakar in the first half of this webinar, and so many of you have submitted questions to us before this webinar, which we will try to address one by one if we could. And one of the more common questions that I found very interesting, which was submitted by more than a couple of individuals since the last webinar, was about Manitol. So what about Manitol and its potential use for Parkinson's? So I prepared a few slides for on this topic. So Manitol is a supplement. It's actually a sweetener. And it is poorly absorbed in the intestines, and therefore it doesn't raise your sugar as much as regular sugar. Now, it also is a diuretic, an osmotic diuretic, so it attracts both water and salt, and this is excreted now mainly through your kidneys, and therefore this is actually being used therapeutically for patients, for instance, in the ICU with brain swelling from trauma, or from a bleed in their brains, and so on and so forth. It's also being used to protect your kidneys during heart or vascular surgeries. So the impetus for the interest in Manitol started in 2013 when there was this basic scientist that showed that if you introduce Manitol into a test tube where there are toxic clumps of alpha-synuclein. And for those of you that have attended the previous webinars, we talked about this protein called alpha-synuclein, which clumps, which misfolds, which aggregates in patients with Parkinson's disease and multiple system atrophy and dementia with Lewy bodies, so-called synucleinopathies. And it is this misfolded protein that causes cells to die. And it is alpha-synuclein, the misfolded alpha-synuclein, that is the ingredient of that pathological hallmark of Parkinson's called the Lewy body. So anyway, back to this Israeli study, what they found was if you introduce Manitol into a test tube with toxic clumps of alpha-synuclein, what happens is that the alpha-synuclein aggregation gets reduced or gets reversed. And so the misfolded alpha-synuclein binds to the Manitol, and they think that the way this works is that it signals now the inherent mechanisms that get rid of this misfolded proteins in your body, in your tissues, in your cells. It then signals it for disposal. So in animal models of Parkinson's where they introduced Manitol, they found that there was improvement of the so-called Parkinsonism of these animals. And so this led then an Israeli individual with Parkinson's to take Manitol long-term for several months, and he noted improvement. So he was trying to drum up interest for research to be funded for Manitol for Parkinson's, except that nobody was interested. Why? Because it's cheap. You can buy this in the grocery store. If you live in the US, you can buy this easily in Amazon. So therefore, there was really no financial interest for any company to invest gazillions of dollars for a drug that anybody can buy, from the grocery store at a very cheap price. And so, in lieu of this, he promoted its use online and encouraged Parkinson's patients to report their clinical experience over several months in a platform called ClinicCrowd. And what they found was, and there were like more than 1,500 patients that participated in this. And of those, about 78 patients took it for more than 6 months. And what they found was that there was a 56% improvement, not only of their motor performance, but also some of their non-motor symptoms. And so this has led to a phase 2 randomized control study in Jerusalem in a center called the Hadassah Medical Center. And this is an ongoing study, which I believe will finish in 2022. It's a small study. The funding wasn't really that large. It's actually funded by the Israeli government. And they're randomizing patients to either Manitol or dextrose, and they'll find out long-term whether one group of patients is better than the other. Now, given that this is readily available and that you can buy this even in Amazon, should you be taking it? Is it safe to take it, first of all? Well, the answer is yes, at the low doses that they recommend for use for general health, for especially among diabetics. It is actually present in many of the processed food that you buy from the grocery store. So without you even knowing, you may be actually consuming mannitol as we speak in the things that you just buy from the grocery store. Now, are there natural sources of mannitol? And the answer is yes. Cauliflower, for instance, has 3 grams of mannitol per 100 grams of cauliflower. Now, be careful, though, of the side effects, because if you overdo this, it is not an innocuous supplement. First of all, it can cause headaches, nausea, vomiting, dizziness, dehydration, low blood pressures, palpitations of fast heartbeats, rash, hives, and frequent urination. And then if you really get overzealous and lose track of just how much you're consuming, and you happen to consume more than 20 grams on a regular basis, on a daily basis, then this can lead to bad things. It can act like a laxative. It can lead to kidney failure. It can lead to heart failure and electrolyte imbalance. So just be careful when you use a drug of this sort that's readily available and sort of self-manage your Parkinson's. Okay, so again, one of the more frequently submitted questions was this thing on REM behavior disorder, which is in layman's terms dream acting. So REM refers to rapid eye movement. So this is the deepest stage of sleep. This is a stage of sleep when you dream. Now our creator was so good and so wise that he created an inherent mechanism so that you don't act out your dreams, you don't fall out of bed, you don't jump out of bed, you don't sleepwalk, you don't get a concussion, and so on and so forth. So there's an inherent mechanism built in your body where your muscles are paralyzed during REM. So this is called REM paralysis. Now, what happens though in Parkinson's is that, and also sometimes in elderly individuals, or sometimes when you take certain medications like antidepressants, that REM sleep paralysis becomes inefficient. So now you start moving and thrashing around and talking and yelling. I've had patients that dream walk. I have patients that fall out of bed. I have a patient that actually, walk all the way to the front door and started seeing, people in front of the front door, started yelling at them, go back to his room, then go back to bed, and so on and so forth. So this is not an innocuous thing. If obviously it predisposes you to injury, given that this usually occurs during sleep and at night. So they found out that REM behavior disorder is actually a precursor to a synucleinopathy. So I alluded a while ago to the so-called synucleinopathies. For those of you that want to get a review of what the synucleinopathies are all about, check out the MBFA website. About 2 webinars ago, I think this was in June, we talked about synucleinopathies and about alpha-synuclein and about the approach in terms of research of tackling alpha-synuclein, trying to reduce the alpha-synuclein burden. So if you have REM behavior disorder, they found out that this is the #1 non-motor symptom that predisposes to Parkinson's, MSA, or dementia with Lewy bodies. So what is the rate of conversion? So roughly, the rate of conversion is 6% per year, cumulative. So for instance, if you develop a REM behavior disorder at age 50, so by age 51, you have now a 6% chance of developing one of these synucleinopathies. In 2 years, you have a 12% chance, and so on and so forth. In 5 years, you have a 30% chance. In 10 years, about 60%. In 12 years, about 75%. And 15 years and above, a 90% conversion or more. Now mind you, this numbers vary depending on which studies you read. But the bottom line is that REM behavior disorder, especially that which is proven through sleep studies, because many patients talk about, I kind of observe my spouse or my bed partner talking and yelling at night. But the question is that dream acting occurring during rapid eye movement sleep? So many of us can also be talking in light sleep or lighter stages of sleep, and that doesn't count. The so-called slow stage sleep, that doesn't count. What really counts and what really predicts a synucleinopathy is the dream acting that occurs during the deepest stage of sleep called REM. And mind you, REM doesn't occur in the first couple of hours or first hour or two after falling asleep. This usually occurs towards the tail end, the second half of your sleep, which is why many of our patients that have dream acting tend to do that towards the second half of their sleep. And then a follow-up question that many have submitted is, are there drugs to treat REM behavior disorder? And the answer is the most common one that we prescribe. One is a supplement called melatonin. And melatonin is a substance that you produce in your brain. It is actually the the substance that powers your internal clock. Which is why when you travel from one time zone to another, like for instance, you travel from here to Europe or here to Asia or Asia to the United States and so on and so forth, where night is now day and day is now night. And you kind of have to take a little bit of melatonin to reset that internal clock. Okay, so Parkinson's patients tend to produce less of this melatonin as they get older, and that predisposes them to REM behavior disorder. So if I don't get the RBD controlled with the maximal doses of melatonin, so I usually start with 1 milligram, then go to 3 milligrams, then 6 and 9, and then maybe 10. 12 milligrams is probably the highest I would go. I've had some patients that go up to 15 and say that it's actually helped, whereas the lower dose did not. But once the maximal dose of melatonin has been used, and they're still doing the dream acting, then I move to a drug called clonazepam. I really am not a fan of clonazepam. It's a controlled substance. It's a pain in the butt to prescribe nowadays in the U.S. since you have to do this electronically now. You have to go through certain hoops, especially in Arizona. This has to be monitored and so on and so forth. And so it's really a pain. And obviously, it also causes some side effects. So imbalance in the middle of the night or falls seem to be higher if you take clonazepam. If you're demented, it probably will make your dementia worse, causes confusion in the middle of the night, and so on and so forth. Okay, and then the next question that more than a couple of you have submitted, is there a way to prevent REM behavior disorder or premotor Parkinson's from progressing to full-blown Parkinson's disease, MSA, or dementia with Lewy bodies? So again, the so-called premotor stage of Parkinson's usually spans about anywhere from maybe 5 to 10 to maybe even 20 years. So this starts with poor sense of smell, the REM behavior disorder, the constipation, the anxiety, the depression, the poor sleep quality, mood changes, sweating issues, frequency of urination. These are non-motor symptoms. So is there a way, once you know that you have RBD and you have poor sense of smell, and the more of these non-motor symptoms that you have, the higher the chances you're now in the premotor stage of synucleinopathy. Is there a way to stop that from progressing further? And currently there really is none. Although if alpha-synuclein is in the heart of the causation of this synucleinopathy, the so-called misfolded alpha-synuclein. I wouldn't be surprised if research in the future will move towards that direction of recruiting patients in the premotor stage of a synucleinopathy. Now, whereas currently we have the DAT scan to kind of confirm that you really have, the motor stage of Parkinson's, and that you really have a dopamine deficiency. Is there a way to measure your alpha-synuclein? Is there such a thing called a synuclein scan, similar to a DAT scan? And the answer is currently there's none. Although the Michael J. Fox Foundation has actually put out a call for research in the tune of several millions of dollars to groups that will come up with a way to develop an alpha-synuclein scan. Now, it will be very similar to your DAT scan, or very similar to your MRI scan. You go to a radiology place, they do a scan, and the tracer that they'll use for the scan will measure the alpha-synuclein, not only in your brain, hopefully, but all over your body. Because remember what we mentioned in the webinars, 2 webinars ago about alpha-synuclein, is that this actually starts in the periphery. So the question is, can we measure the alpha-synuclein in the periphery even before it reaches the brain? And hopefully in the future, yes, with this so-called synuclein scan. Now, is there another way, given that the synuclein scan is not, alpha-synuclein scan is not yet available, is there another way to look for alpha-synuclein? And again, we tackled this 2 webinars ago. So you can actually do a skin biopsy. You can actually do a colonic biopsy. You can do salivary gland biopsies. And I think the one that has the greatest consistency in terms of yield and the highest, the least invasive and the highest percentage of being positive, or the lowest rate of false negative would be the skin biopsy. So it's a very simple office procedure. It takes 5 to 10 minutes. We do a punch biopsy behind your neck, around your knee and around the ankle. And then the first lab to actually do this commercially that can be charged to your insurance is actually existing, and it actually is here in our own state, in Arizona, in Phoenix. So the lab is called C&D, or Cutaneous Neurodiagnostics. So after about a couple of weeks, or maybe 3 weeks at most, they send us a report saying, yes, there is alpha-synuclein, misfolded alpha-synuclein in 1, 2, or 3 of the biopsy sites, versus nope, we didn't see alpha-synuclein, and therefore chances are patient does not suffer from a synucleinopathy. Although the rate of false negatives with the skin biopsy is somewhere around 10%. So there's still a 10% chance that even if it's negative, that you still may be suffering from a synucleinopathy. Now, are there false positives though? It's really hard to quantify the false positives, but the general feeling and thinking is that the false positives are really, really low, and that the so-called false positives that don't have any symptoms actually represent the so-called premotor or preclinical, or there's several terms for this, pre-symptomatic or prodromal Parkinson's, MSA, or dementia with Lewy bodies. Okay, hey, Dr. Thakkar, you have any thoughts about what I've said so far?
No, I totally agree. I mean, I probably would say, one of my biggest things is, as I tell patients, that Parkinson's, unfortunately, is a 24-hour disease, and we really have to address the sleep patterns. And, it's very valuable to tackle the need for maybe a sleep study. Don't underestimate that. If there's a mild sleep apnea, it needs to be maybe even addressed as if it was serious, because we know that, the patterns of sleep and the oxygenation and blowing off the CO2 that's toxic can really have long-term consequences. So, but I'm a big believer of managing the REM sleep disturbances with melatonin. We sometimes, some sleep doctors I work with utilize very, very low dose gabapentin, and, try to avoid, as you stated so eloquently about the clonazepam, that, we try not to utilize those as much as possible.
Yeah, I kind of noticed that most of my sleep colleagues are quick to prescribe clonazepam even before they prescribe melatonin, when in fact I get good success in a good percentage of my patients with the proper dose of melatonin. Okay, so next question. I have been diagnosed with either premotor Parkinson's or multiple system atrophy. Here are my questions. Number one, what is the difference between the two? Okay, hey, Dr. Takar, you want to chime in on this one? Parkinson's versus MSA?
Yeah, one of the biggest things is the way you look at MSA is that it's a faster atypical version of Parkinson's. We think of regular idiopathic Parkinson's as a typical, slow progressive, over decades where one may have deterioration, but multiple systems atrophy has this variant of a faster decline in balance, speech, autonomic instability, where patients may have more REM sleep disturbances, blood pressures fluctuating. They may actually have spinocerebellar signs and cortical signs where the toe is sticking up actually. And so we have this decline that may not be quite responsive to levodopa therapy like we would get in regular Parkinson's disease.
Yeah, and then there's really very few ways one can differentiate Parkinson's from MSA. Usually it's long-term. Levodopa responsiveness can be seen in MSA patients, but it's usually not enduring. And in fact, in the autopsy studies where they found that the rate of misdiagnosis is 42% among patients diagnosed with Parkinson's within the first 5 years, the two top differentials that mimic Parkinson's, that were thought to be Parkinson's, are number one, MSA, multiple system atrophy, and number two, progressive supranuclear palsy, which is PSP. And PSP patients usually have tons and tons of imbalance even from the get-go. Whenever I see patients that have imbalance and falls as the initial symptom, I usually think of PSP first and then maybe MSA second. And then the other thing that Dr. Takar mentioned is the autonomic symptoms. So if you were to do an autonomic questionnaire, I usually do that almost routinely now among my patients that present with Parkinsonism, especially those with falls, especially those that present with dizziness. So patients with MSA have very prominent autonomic symptoms. Parkinson's also can, but usually if you're looking at untreated Parkinson's and untreated MSA, these MSA patients, even without being treated, they're already in trouble because they already have orthostatic dizziness, drops in blood pressure, some urinary frequency, maybe some mild incontinence, especially if their bladder is full, maybe some irritable bowel syndrome as kind of symptoms, and so on and so forth. And then when you do a DAT scan, whereas in Parkinson's, a huge percentage of this patient, more than I'd say more than 95% of these patients, if not even more, will have an abnormal DAT scan. In MSA patients, DAT scan can be either normal or abnormal. So a normal DAT scan in a Parkinsonian patient favors MSA, especially if they have autonomic symptoms very prominent in the beginning, and favors less this diagnosis of Parkinson's. Okay. Besides exercise and hydration, is there anything else that can do to slow the progression? I think you're on the right track. Exercise and hydration are really the key. And one more thing that Dr. Takar alluded to: good sleep. So he does recommend, he does send patients for sleep studies and so on and so forth to make sure that you get good sleep. I think if you do vigorous exercise, so it's not just a little leisurely walk to the mailbox or walking the dog at a very leisurely place. No, it has to be aerobic. They found it has to be aerobic, it has to be vigorous, and it has to be sustained. So it has to increase your blood pressure and heart rate by at least 20 points. And if you do that at least 20 minutes every day, that's probably good exercise. If you can do more than that, then well and good. Okay, another recommendation is to make sure I have lots of electrolytes. Does this impact the kidneys? I found a supplement that you put in water called Ultima Replenishment. Any thoughts on this versus Gatorade or similar? I wasn't familiar with Ultima Replenishment. I actually checked it out when I received this question, and it's simply just a combination of the essential minerals and stevia. which is a natural sweetener, which is plant-based. So it looks like it's a good electrolyte balance, non-sugar hydration thing. But I don't think there's any studies that show that one of these brands or types of electrolyte water or fluid hydration is better than the others. Do you have any thoughts on that, Dr. Thakkar? Do you agree?
Yeah, I totally agree. There's not really much specific evidence about it on those, but again, keeping inflammation low with certain types of sugars, I think those are the key things. We always try to say keep minerals high, appropriate minerals high, and again, I think you alluded to earlier about salt, and we want to really have the ability to rehydrate, but also the muscles to relax after a vigorous exercise. So these are key things where some degree that we may need some protein, but be mindful that how it may interact with levodopa too.
Absolutely, yeah. Okay, and then is there anything in my diet I can minimize or add to in order to slow the progress? So I would refer you again to an MDFA webinar, which you can find in the MDFA Facebook page. This was 2 webinars ago on diet. And so I also gave a talk maybe a couple of years ago, and I found I found 2 slides which talked about diet and alpha-synuclein levels. But again, these are just conjectural recommendations. There's not really hard science to back up these things. Most of these things are based on basic research, but not in actual human studies. But they think that consuming high levels of flavonoids, which means vegetables, fruits, berries, nuts, peppers, beans, a little bit of red wine, black tea, not too much of the wine. And again, many of my patients ask me, what's not too much? What is a mild to moderate amount of wine or alcohol? And so a recent paper I read mentions about 4 or 5 ounces of alcohol for women per day, and then double that for men would be the limit in terms of consumption of any alcoholic beverage. And then they feel that they think that the flavonoids are neuroprotective. They actually are very powerful antioxidants. And not only do they help modify the alpha-synuclein levels and prevent the clumping and the aggregation and the misfolding with alpha-synuclein, they think that there's a lower incidence of dementia in these patients as well. Now, mind you, in dementia, the protein that, especially in Alzheimer's or even in non-Alzheimer's dementia, like PSP, the protein that misfolds is called tau. And they think that many patients, especially those that are exposed to environmental toxins or to pollutants or highly polluted, living in highly polluted cities, can be more prone to misfolding of multiple proteins that lead to neurodegenerative disorders. It was a very intriguing study that I read very recently. So alpha-synuclein is one of them. So it may predispose you to Parkinson's, MSA, dementia with Lewy bodies, and then there's tau, misfolding of tau, that predisposes you to Alzheimer's disease. And then there's another protein called TDP43, which is again a protein that we see in another neurodegenerative disorder called Lou Gehrig's disease or ALS. So they think that some of these patients, and they actually looked at some individuals who live in this very polluted areas and they donated their brains to science. They found out that those that live in polluted areas have more of these misfolded proteins, even those that have no symptoms. In other words, they're still too young to develop a symptoms of a neurodegenerative disorder. And then they actually did there was a little study that I found on this flavonoid, which is found in a Chinese herb called bakelin. And they found that it actually inhibits the aggregation, the clumping of the alpha-synuclein. Again, that gives you basic science evidence that maybe truly, despite the absence of good human clinical studies, that maybe what I eat can modify the alpha-synuclein levels in my body. So the next question is, can what you eat influence misfolding of the gut alpha-synuclein? So why are we interested in the gut alpha-synuclein? Because as we had mentioned previously, the accumulation of misfolded alpha-synuclein starts in the periphery. It doesn't start in the brain. In the so-called preclinical premotor stage, which is anywhere from 5 to 20 years before you develop the first symptom, motor symptom of Parkinson's, the misfolded alpha-synuclein has actually started to accumulate in the periphery, in your skin, and also in your gut. And so, and this can be influenced by what you eat. And so what food items, experimentally, what food items have been shown to cause misfolding of alpha-synuclein, and therefore theoretically can cause accumulation of alpha-synuclein, misfolded alpha-synuclein in your gut. So these are processed food, pesticides, especially fresh fruits and vegetables. I guess even if your fruits or vegetables look clean, and they were supposed to be pre-cleaned when you purchase them in the grocery store, I would recommend that you really wash them well and good, and get rid of every particle of potential pesticide that was utilized to make sure that they don't get pest ridden. Then excessive sugars, preservatives, polyglycerol, lecithin, and heavy metals in your water. The number one heavy metal that seems to be associated, at least in experimental studies, of causing misfolding of alpha-synuclein is manganese. And in fact, we've seen Parkinsonism among miners that mine manganese. It's called manganeism. And in fact, a manganese exposure can lead to acute Parkinsonism, or can lead to long-term changes through alpha-synuclein that eventually lead to Parkinson's. So this is one of the heavy metals that unfortunately is in your water, especially if you drink well water. And this is the main concern about whenever Dr. Thakkar and myself ask you, did you live in a farm when you were growing up? Did you drink well water, and so on and so forth? We're actually interested in this, the manganese content in your drinking water. And then the altered gut flora. So also fosters misfolding. So there's normal healthy bacteria in your gut, and that bacteria is supposed to assist with digestion. And what happens in Parkinson's, because of this alpha-synuclein that misfolds and accumulates in the nerves, the autonomic nerves around the walls of your intestines, all the way, or your gut, all the way from your throat to your esophagus, to your stomach, and all the way down to your rectum. What happens is that the contractility of the muscles around the GI tract becomes inefficient, and therefore there is now accumulation of bad gut flora and reduction in the good flora. And this accumulation of bad bacteria in your gut fosters misfolding of alpha-synuclein. So that's one of the things that they theorize can be associated with increased incidence of Parkinson's down the road. Okay, any thoughts, Dr. Thakkar? Okay, I think we might have a time for one or two more slides. So is there a link between diabetes and Parkinson's? The answer is yes. There's an increased risk of Parkinson's with type 2, not type 1 diabetes. In fact, there's a 30% increased chance of developing Parkinson's with type 2 diabetes. So type 2 has to do with insulin resistance, not so much with a reduction in production of insulin. It's you produce the insulin, but your cells are not able to utilize this. So insulin is important for glucose to be utilized to cross from outside of your cells in the blood vessels and cross over to the cells where they're utilized for energy. So you need insulin for that. So type 2 diabetes patients tend to be more predisposed not only to Parkinson's but also to Alzheimer's disease. And that also leads to another question about exenatide. So we talked about exenatide in the previous webinar. This is a GLP-1 agonist. It's a drug that's being used for type 2 diabetes. GLP-1 receptors are found in the pancreas. So if you stimulate these receptors, you release insulin. And they found out that this same type of receptor is present in your brain. So there was a phase 2 study in 2017, and they used this drug called exenatide, which is actually being used in many patients all over the world, including Asia and Europe and the United States, obviously. So it's a drug that's readily available. So there was a study in 2017 in 62 PD patients, and they administered a dose of 2 milligrams subcutaneous weekly versus placebo, and they found out that the motor scores improved with exenatide. So what they think exenatide is doing is that it is, I'm not sure whether I have that slide over here, but what they think that it's doing is that it is reducing the aggregation or dissolving the aggregated or misfolded alpha-synuclein. So in fact, it is reducing the amount of misfolded bad protein or bad alpha-synuclein. And currently, there is a phase 3 study that's ongoing in the United States. Unfortunately, because of COVID, the recruitment has slowed down somewhat. And so the original target of 2 years duration of the study will probably be longer. Although I wouldn't recommend that you just, twist the arm of your doctor to prescribe you this. But if you have diabetes, though, and you have type 2 diabetes, I don't see any reason why you shouldn't talk to your doctor to take to switch to exenatide. And in fact, they found out that patients with diabetes that are prescribed exenatide and other GLP-1 agonists for their diabetes. And if you compare those with patients with diabetes that were prescribed, metformin and other drugs that are not influencing the GLP-1 receptor, those that were prescribed this GLP-1 agonist develop Parkinson's much less frequently than those that were prescribed some other medication for Parkinson's. So that goes back to this mechanism of action of possibly dissolving or getting rid of this aggregated, accumulated alpha-synuclein in your tissues, whether it be in the periphery or in the brain.
And Dr. Evidente, I got kicked off a little bit earlier, but I got back on when you commented on don't twist the arm of your doctor. And I think that's very important just to state, because we have seen some patients come into our clinic to ask about this.
Exactly.
And cautiously, you cautiously need to, number one, only if you have diabetes should you actually be on such medications, and follow really closely with your endocrinologist if you have diabetes. But we have actually had some patients who tried to get on exenatide, and they had very severe side effects of GI, bloating, diarrhea. Yeah. So again, I agree with you significantly and wholeheartedly that the data still needs to be understood.
Absolutely. So wait for the clinical studies to get finished before you jump on the bandwagon and want to be put on this drug. Despite the fact that you know that it's within your reach, it's out in the market, it's FDA approved. All you need is that doctor to play along with this desire of yours to be put in a drug that so far is promising in animal studies and is promising in earlier phase 2 studies. But mind you, many phase 2 studies that were promising never bore out and were never replicated in terms of efficacy with phase 3 studies. We really need those phase 3 studies to show us that these drugs are truly efficacious when given to a large number of patients. Number 2, that they are safe. Okay, I think we are out of time at this point. I'd like to thank everyone for tuning in. I'd like to thank Dr. Thakkar for being such a great speaker and a great sport, and for sparring with me in this questions and answers format. We encourage you to submit more questions between now and the next webinar that we hopefully will be able to answer as well. And so at this point, I'm going to turn over the platform again to Cindy.
Our next webinar will be held on Friday, February 12th, 2021. We will send out information for joining via email next month. Thank you, Dr. Evidente and Dr. Thakar, for sharing your expertise and experience with movement disorders and Parkinson's disease. To conclude today's webinar, I would like to acknowledge and thank all of our sponsors: Boston Scientific, Medtronic, UCB, Neurocrine, Kiowa Kirin, Adamas, Accorda, and AbbVie. Dr. Evidente mentioned our previous webinars. You can visit our website and click on the resource tab to view our previous webinars. Finally, I invite you to assist us in continuously improving the quality of these webinars going forward by answering a short survey, which you will receive via email. Your response to the content and format of our webinars helps all of us and is greatly appreciated. Thank you all and have a great evening and morning. Goodbye.